Welcome. We are eager to introduce you to Jeff Krings, who's a family nurse practitioner and with us today. And he is here to talk to us. And if you have COPD or allergies, this may be just the class for you. Jeff, thank you for being here, and we are eager to hear what you have to share with us.
Thank you, Gretchen. Thank you, everyone, for being here today. I hope this is helpful, but I will say that this is a very advanced topic, and today's presentation is going to be just a sand pebble in the complexities of COPD. Just a little brief history on me. I started working for NCBH in 1998 as a nursing assistant while I was in nursing school. Graduated, worked in the MICU for 12 years, and then got my nurse practitioner in 2012 and specialized in severe asthma and clinical trials in asthma, COPD, and cystic fibrosis. So I don't do much in my spare time. I split my clinic in the mornings. We're doing clinical trials, and in the afternoons, I do real clinic. All right. So COPD is defined as a disease state characterized by persistent respiratory systems and airflow obstruction. This includes emphysema, which is anatomically defined as a condition characterized by destruction of the lung alveoli with airspace enlargement. Chronic bronchitis often gets mixed in here, but it's defined as a chronic cough with phlegm and sputum production. And then small airways disease affects the small bronchioles in the further distance part of the lung. Asthma, on the other hand, is defined as a disease characterized by episodic airway obstruction and inflammation. And let me get my slide caught up here. I apologize. All right. One thing about COPD is if you have a smoking history, that does not give you a diagnosis of COPD alone. It really should be diagnosed based on spirometry, and that's something I enforce very highly in my clinics. Reactive airway dysfunction syndrome presents like persistent asthma following an acute exposure to an irritant inhalant. And there was a study done in World War I. They took 10 healthy individuals and they exposed them to nerve gas or gases, and it triggered respiratory symptoms. And this was separated out currently as the smaller airways, more distal in the lungs, they get more irritated from things that we inhale in our environments or from smoking. This is what we call a spirogram, and what's presented is a normal spirogram. And this is, you'd come in and sit in a chamber to do a breathing test. And over here, you see where you breathe in, you blast out, and this is the last part of your effort. This takes about 6 to 8 seconds to get a good effort. And typically when we test you, we make you do 3 efforts. Over here, you see where COPD, you're not forcing out as much as you can, but you still get your vital capacity out there. You just can't get it out there fast enough. And this peak here would be less, and this curve would be a little more pronounced. And the same thing with asthma. But in COPD, this curve won't go back to normal. In asthma, it can get to normal, but it doesn't always get there, depending on the severity of the disease. All right, allergies and allergens are defined as sensitization to particular allergens through production of allergen-specific IgE and upon exposure to those allergens by inhalation. And these can cause a result in activating mast cells and basophils with an acute bronchoactive mediator, which produces immediate bronchospasm or an early response, or a late response, which is called which is in 2 to 24 hours after exposure, with resulting narrowing and inflammation of your airway. Now, this may seem pretty obvious, but have you ever been exposed to any of the following? Have you lived in a home, an apartment, gone camping, You've gone outside, you've worked in a garden, you've painted anything, inside, outside, art, whatever. Clean carpet, painted your nails, used hairspray, experienced a viral, bacterial, fungal infection. You've cleaned a child, dog, or cat waste. You've cleaned your home or your car. You've worked anywhere in a factory that has chemical, furniture, oil refining, biomass, cotton, mining, wood, gas, fireplace. Have you ever welded? Have you ever mowed the yard? Have you ever smoked anything? Anything and everything can be an irritant or an exposure or a trigger. What does that have to do with you? This is where we live. We have all these triggers that we're exposed to. Whether you can control them or not, this is our environment, this is the world we live in. We have exposure to, excuse me, dust from the Sahara Desert that crosses the Atlantic and come over in the summer. We have wildfires either from California or Canada that exposes us to things. The world's getting smaller, it seems. So what is our respiratory system designed to do? It is designed to obviously take in oxygen and exchange it for carbon dioxide. These alveoli, and as I presented in clinic, I call them grapes. So the smaller grapes you have the more contact time or contact you have with gas exchange with the cell wall, alveolar walls. With emphysema and COPD, these grapes go through a cell wall destruction and they may seem bigger, but they have less gas exchange. So there's less surface area that actually exchanges oxygen and CO2. So you'll see somebody with COPD who's more of a barrel chest because they're trapping air and they can't always get it all out. But this is just a normal one. This is a normal chest CT. This is one slice out of a many. So this just really just emphasize that you'll see your heart, your airways, more airways, some vessels, and this looks good. And it's grayed out and it's fine. It's never going to be clear. So if you're expecting to see like, it's just blacked out and it looks gone, that's not true. A little gray area so we can see the anatomical features is fine. This is not a normal CT scan. And this is so much more complex than what I've trained to tell you, but I know what's abnormal and when to escalate care to a pulmonologist. So, but this is what an abnormal chest CT would look like. Again, this is your heart, and then the airways looking at it from the front view. All right. So again, when we breathe in these irritants, we induce a series of chemotaxic reactions that are chemical and physical in nature, and depending on the molecular weight and size of those irritants determines whether it affects the larger airways or the smaller airways. So based on the setting, velocity and air particles, again, greater than 10 to 15 micrometers in diameter, do not penetrate beyond the nose and throat. Particles less than 10 are deposited below the larynx, okay? So your throat. Those particles divided into three size fractions based on the size characteristics. Again, 2.5 to 10 microns is very coarse. It may contain crustal elements like silica, aluminum, and iron. And it's one thing we always ask with a new patient who has breathing problems is, where have you worked? Have you, like, you work in the dirt? Do you use a respirator at all? Are you mining, farming, whatever? All right. Although the total mass of an ambient sample is dominated by the larger respirable particles, the number of particles, and therefore the surface area in which they potential toxic agents can deposit can be carried to the low areas is dominated by particles less than 2.5 micrometers. And this is created primarily by the burning of fossil fuels or high temperature industrial processes resulting in condensation products from gases, fumes, or vapors. So if you're thinking, well, car exhaust, no big deal. No, it actually is a big deal. And that's why it's so important, to keep your cars well tuned and not pollute. This is a very I'll call it a Reader's Digest version of the inflammatory cascade. But you have high molecular weight, low molecular weight. They both land on the epithelial lining of your airways, and they set off all these chemical reactions. There are therapies in the market now that can kind of block these cascades. Specifically, we have IL-5, IL-4, IL-13, and TSLP biologic injections that can help block that. And we're having really good success clinically in research again, clinically, sorry, doing really well with that. Now, so how do we minimize our exposures and not drive ourselves crazy and start a panic? We wear masks. We don't wear masks that have all the bling on them and that look like the cloth mask like we had when COVID first started. But we should use a proper procedure mask or an N95 mask that you can get from any, you can get them from hardware stores, you can get them from pharmacy, wherever. We need to filter our homes. The question we ask a lot in clinic is, do you change your air filters regularly in the home? That should be done every month. I have 5 dogs and a cat. I change the filters every 3 to 4 weeks. It's ridiculous, but got to be done. In your car, you have a cabin air filter. That should be changed, I say, every 3 months, depending on where you live. And again, if you have pets and the pollen bothers you, change that filter out. It will make a difference in your vehicles. All right. So this was just meant to be an example of how I tell everyone in clinic, how do we control nasal sinus allergies? I promote nasal hygiene. What does that mean? You wake up in the morning, you blow your nose. Then you spray each nostril with some nasal saline spray, not just like contact solution, or don't make anything from home. This has to be sterile. Nasal saline spray, blow your nose, and then you can use a nasal steroid spray itself, like Flonase, Rhinocort, or Nasonex. I have no stake in any of these. All of them work just fine. Everybody responds different. They all have a very good safety profile. They do taste like pollen, some of them. Not sure how that got through marketing and development, but they did it. But it does work and it does relieve your symptoms. In our area, I have found that fexofenadine or Allegra is an excellent antihistamine that works 24 hours a day, doesn't make you sleepy, and compared to what blows off the mountains from West North Carolina to here, is better than Zyrtec, Claritin, or Zysol. Nothing against antihistamines in general. That's just our area, and that's just what I found. It's what I use. If Allegra doesn't work for you, try the other ones. Like I said, everybody's different, and that's fine. But those have been found to work very well. There was a recent article from 2024 on how effective the last 25 years have been for fexofenadine. So that link is there if you want to look at it. First generation antihistamines do have a problem with sedation. So they have their place, excuse me, they have their place in treatment, like Benadryl if you're having an allergic reaction to something, but it can make you sleepy. So it's not something I recommend all the time. I do have patients who are on Allegra during the day and Benadryl at night, and they're doing just fine. To moisturize your nose, there's things called air gel or nasal gel, which are more water-based than petroleum-based, and those work well too. You just have to apply them a few times a day. Now, people who smoke, who are on oxygen, I don't recommend that they use Vaseline to moisturize their nose in extreme circumstances, because that is setting yourself up for a fire accident. We have had people set themselves on fire. So I warn people, if you're a non-smoker, you're not on oxygen, you can use Vaseline. If you're on oxygen, don't do it. Don't need to. You'll have 1 out of 3 of the requirements to start a fire. We don't need to add anything to it. Put yourself more at risk. So should you stay inside? No, absolutely not. We're not designed to be couch potatoes. We get deconditioning the minute we sit down and just start relaxing all the time. The next thing you know, it's like, oh goodness, my endurance is gone. I can't do what I used to do. So We are designed to be active. Now, all of us have our own limitations, but I chose some of these Paralympians because they've got to overcome, oh, I've got it, not just a disease, but I'm missing limbs and I'm doing cross-pool Olympics. You know, I'm riding in a wheelchair, racing in a wheelchair, doing well. Excuse me. And then these other two pictures are of, you know, neighbors just helping each other out. This picture here represents life in general. We all have an uphill struggle regardless of what our comorbidities are, but we can go out and live a pretty good life. Now, I know everybody, some of us have more limitations than others. And if you're having problems breathing, we do have pulmonary rehab, which can help us with breathing techniques, recommended exercise, but there's a lot of craziness in the world right now. And I know it's hard to say to get out there and enjoy it, but get out there and enjoy it, make a positive impact. But again, this slide, excuse me, getting dry. There are many triggers in our world that can affect our lives regardless of our medical conditions. But if we can get our conditions effectively managed, we can live our fullest life. We only have one life, enjoy it while we can, help your neighbor, help yourself. And again, pulmonary rehab and clinical trials may help or offer newer therapies that may help you as well. And again, embrace life. We all have a condition. Go be your own superhero. Be that inner child. Don't be afraid to introduce yourself to people, and just, you know, take on the day. And with that, I am done. Any questions?
Thank you so much, Jeff. We appreciate all the information.